Next speaker, Dr. Preeti Rastogi. She is head of department at Medanta. She'll be talking about history and obstetric management in FGR.
Hi, it's good afternoon, everyone. So I think the basic classification for IUGR, the ultrasound and the Doppler finding, and a basic idea for how to deliver and when to deliver is being already discussed. But what I felt is that this is the discussion which we already had. That as an obstetrician, it's our responsibility to do a screening at the first visit when the women visit you with a urine pregnancy test positive, to understand that what is the risk for that women, so that the further plan of care can be defined. So it's very important that we should all concentrate on taking a proper detailed history and the factors which are important for diagnosing or detecting or putting the women in a criteria that she's at high risk of developing IUGR is anemia, advanced maternal age, history of smoking, alcohol, and illicit drug. Most of our most of the people I find a bit hesitant in asking for smoking and alcohol, and nowadays it's quite important to ask for illicit drug as well. And we should be asking a leading question to the women rather than working around and asking indirect questions. Air pollution is now being documented to have an impact on the growth of the baby, and because we all live in Gurgaon, so that's an important factor for the IUGR. Maternal weight, if the maternal weight is low at the start of pregnancy and if woman is suffering from any malabsorption syndrome. Obstetric history we all know, so I'm going to skip this. Then if we discuss the fetal growth restriction common etiology, we can divide that in suboptimal and the fetal disorders. In suboptimal uteroplacental perfusion of fetal nutrition, we can have preplacental, placental, and postplacental. This is just to remember when we are doing the OPD, and it's a quite busy OPD. So just to keep in mind the different factors so that you can screen the women quite quickly. So in preplacental factors are the chronic lung disease, anemia, smoking, alcohol, substance abuse. In placental factors are the preeclampsia, gestational diabetes or the diabetes, chronic kidney disease, and the liver disease. They all come in the maternal vascular malperfusion pathology. Umbilical cord pathology, they are mostly on the ultrasound, but then we need to know that what is the significance. So if there is increased cord length, true cord knot, single umbilical artery, marginal or filamentous cord insertion. And the fetal disorders, so genetic disorders, structural abnormalities, and the congenital infections we have already talked about. So TORCH, syphilis, and the new Zika virus, they have been shown to be this predisposing factor for the IUGR. And the question is that why we are worried about growth restriction. So we all know that most worrying reason for IUGR is a stillbirth. And we also know that IUGR is being in association with preeclampsia, placental abruption, and preterm birth. But the most important factor which worries all of our mind is a neonatal morbidity and mortality associated with preterm baby and a IUGR baby. And the long-term implication which the baby can have after survival, which is neurodevelopmental disorders and the metabolic syndromes which are evident after birth. So it's quite important for all of us to have an early prediction. An early prediction, we can be using these different features like on history, then the biochemical markers. So on double marker screening, if the PIGF and the PAP is low, if it is an advanced maternal age and we are doing a PIGF for the PET screening, and if both are low, and in quadruple marker, high alpha fetoprotein. Then ultrasound markers we have already discussed. And there is a definite role for preconception counseling in reducing the incidence of IUGR and complicating pregnancy. So adopting healthy lifestyle, optimizing the maternal condition, and optimizing the BMI. It's quite important. We also need to emphasize on the appropriate weight gain during pregnancy. So these are the optimal weight gain which women should have according to their BMI. We need to ask the women to stop smoking. That is quite important. And if the smoking is stopped before 15 weeks of pregnancy, the chances of IUGR can be reduced. The most important is Prevention of IUGR. So if in case, suppose on history and an examination or an ultrasound finding, we find that this woman is at high risk of developing IUGR, what is the role of aspirin? So there have been many trials, out of which the main trial which was done to see the role of aspirin in reducing the incidence of IUGR was not supporting the use of IUGR, aspirin only for the IUGR, but there are other evidence and the studies which have shown that if aspirin is used in a woman who have a high risk of developing preeclampsia later in the pregnancy, then it also reduces the incidence of IUGR. So there is a role of administration of aspirin before 16 weeks of pregnancy, and it reduces the risk of IUGR by half. The dose of aspirin is being defined 100 to 150 milligram, and in one study it is being seen that the evening administration of IUGR of aspirin is more effective than morning administration. If we talk about the low molecular weight heparin, it is not proposed for the women with IUGR alone. So there was a trial where they have evaluated the role of enoxaparin in prevention of preeclampsia and IUGR, and they have found that if the woman has a preeclampsia abnormal Doppler and IUGR, then yes, there is a role of low molecular weight heparin, but not just for the prevention of IUGR alone. And how do we detect the fetal growth restriction? Of course, in OPD, we do a fundal examination. But just to emphasize that the sensitivity is quite low, specificity is about 87%. And the other factors which can interfere with symphysiofrontal height are obesity. Most of the women are of high BMI nowadays, uterine leiomyoma, and polyhydramnios. Role of third trimester in ultrasound in assessing the growth we have already discussed. So if we come to the management, most common etiology of IUGR is a placental dysfunction. And in early onset IUGR, it's the increased umbilical artery Doppler, which is a primary late limiting step for the subsequent deterioration of cardiovascular and biochemical markers. The primary management challenge for IUGR and our concern is the fetal deterioration and the stillbirth, and undergoing versus neonatal morbidity and the mortality which is associated with the preterm delivery. In late onset IUGR, after 32 weeks, the cardiovascular deterioration in response to the fetal hypoxia, which is predominantly confined to cerebral circulation with little umbilical artery Doppler changes. As we know that there is no effective antenatal treatment for placental dysfunction, and therefore once the IUGR is identified, the principal management steps are fetal surveillance and determination of appropriate threshold for delivery. And it is also being seen that the perinatal outcome are improved when the pregnancies are managed in a higher level fetal medicine and neonatology unit, utilizing a uniform management protocol. So this we have already discussed. So let's consider an uncomplicated fetal growth restricted baby. So the finding is less than third centile. Risk of stillbirth is low. The suggested monitoring is that we do Doppler for umbilical artery and MCA 1 to 2 times per week, growth scan every 2 weeks, and delivery at 37 weeks. We can consider doing a biophysical profile or NST depending upon the resources available. The proposed time for delivery is 36 to 38 weeks. Cesarean section to be done only for the maternal indication, but not for the IUGR. This is for uncomplicated FGR. FGR with the mild abnormalities. So findings are umbilical artery PI more than 95th centile, oligohydramnios, suboptimal interval growth, and suspected preeclampsia. Still, with the continuous monitoring, the risk of stillbirth is low, but we should consider an inpatient monitoring. We should consider steroid for the fetal lung maturity. The biophysical profile or CTG should be done one or two times per week, and the Doppler should be done once or twice a week, growth scan every 2 weeks. The suggested plan for delivery, we have to individualize the monitoring and the care, and it could be somewhere between 34 to 37 weeks. Mode of delivery mostly is cesarean section, but if we are near 36 weeks, you can plan induction with continuous monitoring. The most important is FGR with the umbilical artery abnormal Doppler. So if there is absent end-diastolic flow or a reverse end-diastolic flow, then the overall risk of stillbirth is quite high. and the median time for deterioration for absent end-diastolic flow is 5 days and reverse end-diastolic flow is 2 days. So this type of patient, they definitely need an inpatient monitoring. You need to consider the steroid for fetal lung maturation. As I said, that we need to have a departmental agreement along with the obstetrician and the neonatologist about the antenatal steroid, at what duration we are going to do, whether we need to do a repeat dose if required. It should be in always discussion with neonatology team. Ultrasound means Doppler every 1 or 2 days and growth scan every 2 weeks. For absent and diastolic flow, as we said, the delivery should be, we should try to continue pregnancy till 32 weeks if possible. Reverse and diastolic flow till 30 weeks, and mode of delivery is going to be cesarean. This is quite important. If there is an abnormal ductus venosus Doppler, then we should plan delivery between 26 to 30 weeks, and the delivery modality is cesarean. Steroids we have discussed. Magnesium sulfate is for neuroprotection, is quite important if you are planning the delivery before 32 weeks. Sometimes there is an obstetric dilemma that we decide that we might have to plan delivery in next 24 to 48 hours, and we give steroid and we start the magnesium sulfate. And after 2 days, when we repeat a Doppler, the Doppler improves. So if it is like an absent and diastolic flow in 1 or 2 loops, we might predict that it might deteriorate. But then after 2 or 3 days, the Doppler improves. Even if we give magnesium sulfate for the neuroproduction, it is not necessary or mandatory that we should deliver the baby. We can still continue the pregnancy. So the dose is 4 gram IV loading dose along with the maintenance dose for 24 hours minimum before delivery. But whatever number of hours or duration we can give before delivery, that's going to be protective for the baby. This is just an overview that what are the research which is being undergoing for the IUGR. So there is a role of sildenafil which is under trial. It leads to the vasodilatation and can improve the umbilical artery and middle cerebral artery Doppler. The newer gene therapy, there is an Everest trial which is going on. Then the role of protein pump inhibitor and provastatin, which is being going on. And then other novel therapy is nanoparticle and microRNA that deliver drug locally to the uterine artery endothelium or trophoblast to improve the uterine blood flow and the placental function. Right, thank you. I had a case, but then I think it's being already discussed.